on Angus surgery. I don't have any financial disclosures, and it's going to be obvious throughout this talk, I think. And I happen to be a very opinionated person, so I have to admit I'm choosing the studies that support what I think is true. So, angle-based procedures have been observed for children for decades, and we have to give credit to Edwin Smith for being the first to describe it in adult eyes back in 1962, where he used the nylon filament that he threaded circumferentially, and interestingly, the first trabeculotomy was a circumferential one. But he faced a problem threading the nylon suture because it used to stop at multiple locations. They had to create multiple scleral cut downs to retrieve it. And for this reason, probably the technique did not become popular, and that meant another half a century of blebs for us. And it wasn't until the early 2000s when we started looking at the angle again and exploring the potentials for reducing the pressure at the level of the inner wall of Schlemm's canal and the adjacent trabeculum, where we know around 70 to 80% of the resistance lies. And it started with people trying to convince us that a 120 micron hole would solve our problem, and when this didn't work, they thought maybe 230 micron holes, and then when it didn't work, it was 3 holes, and the more the holes, the more you know, this is just not working. And it took 20 years for eye stents to be approved as standalone procedures. They were just approved in 2022, and only last year, this real-world data study from Australia showed that at 12 months, they failed to show any significant reduction in IP as a standalone procedure. At around the same time, in the early 2000s, the trabectome was introduced, and the trabectome removes a strip of the inner wall of Schlemm's canal and the adjacent trabeculum over 120 to 160 degrees. But the device itself was very sophisticated, so it comes with a console. It may not be affordable for many places. So when Medica Hook introduced the KDB, it became much more popular and convenient. And to me, at least, it makes more sense to peel off this layer of resistance rather than just stent it or perforate it. And the studies that compared KDB to eye stents, this is from a review of 14 comparative studies between both, were very much in favor of KDB goniotomy. And then in around 2010, studies on pediatric glaucoma started to show that circumferential trabeculotomy may be superior to limited extent incisions or conventional goniotomy and trabeculotomy. With the introduction of the illuminated microcatheter, we could perform a circumferential trabeculotomy in children, and it brings down the pressure to the episcleral venous pressure of 8 to 10 in those eyes. And all studies that compared both procedures were in favor. They showed a high success rate and more IP reduction in pediatric eyes. So how about adults? Some studies started to show that the same can apply to adults too. So when you incise more of the angle, you get a lower pressure, and even if it scars later, you're more likely to find patent parts of the angle that were not scarred and still filtering. And then in 2014, GAT was introduced. And GAT, I think, is an ingenious way because it allows you to incise the whole inner wall of Schlemm's canal through a single MBR incision, completely conjunctiva preserving, using a microcatheter or a non-industry supported fibroprotein suture. And the initial results showed a 37% IP reduction in primary open-angle glaucoma, and a 50% in secondary open-angle glaucoma. And since then, there's been an array of studies on GAT in multiple types of open and angle closure glaucomas, primary and secondary. And we know that the 4-year outcomes showed a 63% chance of having a pressure of 15 or less, with 44% of patients being off medications. Again, more support in these studies for circumferential incisions. So cases where the GAT could not be completed circumferentially did worse. They were 2.5 times more likely to fail when compared to KDB, which is basically the same thing, but at a smaller extent. The GAT was significantly better in terms of IP reduction and success. We know now that GAT is one of the few, or maybe the only mix that works in advanced glaucoma patients. So studies that have tried to look at the stage of glaucoma as a risk factor of failure found that it does not make a difference. So you can get very high success with some advanced cases and poor success, conversely, with early glaucomas. We also know that you can perform angle surgery after a previously failed filtering procedure. So the angle is forgiving, and having a previous glaucoma surgery is not a risk factor for failure. In this 2-year outcome study on GAD following glaucoma surgery filtering procedures, the complete success rate of medications at 2 years was 61%. So these are eyes that have one or multiple filtering procedures. They usually advance, and they ended up with very successful outcomes at 2 years. Of course, we have challenges, nothing comes without, and bleeding is one of them. High few markers in around 30% of angle surgery eyes, particularly the incision ones, and particularly if you go circumferentially. But most of them are self-limited. You very rarely need to go in and wash them. A more serious complication is eyepiece spikes, and the scary bit is we don't know why they happen. It's been reported in up to 75% in juvenile open-angle glaucoma eyes, they're more likely to spike, but generally in the general population, it's around 1/4 of the eyes. And it usually happens in the first week and lasts for 5 to 10 days, but during this time it definitely carries a risk on a compromised optic nerve. We know steroids are accused of causing spikes, but even if we stop them completely, or we don't use them completely, some patients do still spike. Another challenge is the collector channels, which we know very little about, and they contribute to some of the outflow resistance. So 1/3 of the resistance lies in the distal outflow pathways, which we know very little about. There are studies that have tried to evaluate the collector channels and beyond, to be able to individualize the treatment to patients who can benefit more from angle surgery. So if you have a patient that has most of the obstruction at the distal outflow level, then these patients may probably be more benefit more from filtering procedures. There's a learning curve to angle surgeries. It's more with trabeculotomy compared to GAD, and then iStents. 30 seconds. And finally, last but not least, it's very hard to have a mind of your own under the pressures from the industry, from your peers, the ones that tried new stuff and they just want to, they're happy with the outcomes. It's so hard to have a mind of your own amidst all this. So I think the only thing we can do is just be aware of this, recognize it, and try it for ourselves. Thank you very much for your attention.